Press star, then 0. I would now like to turn the conference over to your host, Dr. Robert Moon. You may begin.
Great. Welcome, everyone. We appreciate those of you that have joined us today. I know we have over 90 lines already that have called in. I expect there'll be more as we go a few minutes into the presentation. As we said last week, the purpose of this call is to do a Q&A session relative to the Integrated Provider System program and to try to be helpful in that regard. Some of you have submitted questions already in recent days, and I think some are even coming in now. We'll try to answer as many of these as we can, and we'll eventually open the phone lines up to your comments. I do have some other folks associated with Medicaid that are here with me to help answer some questions. So hopefully it will be useful to you. I do want to make a few just general opening comments so you can understand just a tad bit of a refresher from what we talked about last week. I do want to emphasize a few key points. First of all, this presentation assumes that you have a basic knowledge of RCOs and generally what we're trying to do. It also assumes that you have some understanding of the 1115 waiver, that is allowing the RCO work to progress, and the fact that there is money from the federal government via the 1115 waiver, and it's the discussion today is about the expenditure of some of that additional money that comes from the 1115 waiver to help accomplish healthcare transformation in our state. A point I referenced last time and stressed, and I'll stress it again today, is that everything I say is pending CMS approval. We don't necessarily anticipate it being a whole lot different from what I'm going to say today, but certainly it's possible. And it may be that the very key point that's most important to you today that I talk about, CMS makes some modification to. But the reason why we're going ahead is we felt it was very important to get out as much information as early as we could so that providers could begin to come together and talk about plans and what they might be able to do. Our timeline is important. Last time I stressed the timeline, I do want to make mention of that again. The timeline is aggressive. There is no doubt about that. However, the reason it's so aggressive is because it's driven by the approval dates on our waiver. The waiver becomes effective April 1. Literally in just a few weeks, and then runs for a 5-year time period. That waiver approval timeline is what drives the IPS timeline. So I do want to stress those things to you, and we had a nice slide last time that sort of discussed the timeline, and you could see that. If you missed our presentation last time, it is recorded, it's on our website. You can go back there, look at it, listen to it, and actually even download the particular slides that we had. Lots of information there in addition to the IPS fact sheet, which is 6 or 7 pages long, has a good bit of information there also. But to quickly reference the timeline, it discusses education of the IPS program starting in March, which obviously is now, going through until the end of May. It also references the fact that there is a required submission of an IPS letter of intent, which is different from your letter of intent that you perhaps have signed to affiliate with one or more of the RCOs. But the IPS letter of intent will be due by April the 15th. Obviously, just a month away. So there is a lot of work to be done. As I said last time, this is not something you come back to in 3 or 4 months or 6 months. No, this is work to work on right now, and that is important now. An IPS application, which is required, will have to be submitted. The time frame begins early May and goes through the end of June. After that, there will be public comment opportunity for any of the applications that are submitted, and there will be an actual scoring by a third party to score the applications. And obviously between that scoring and Medicaid's review, then ultimately there will be a decision made about the awards, and the awards are scheduled for being in the month of September. The goals of our waiver are 4 large goals in the sense of improving prevention and management of chronic disease, improving access to and care coordination of health services, improved birth outcomes and health care delivery system financial efficiency. But then there were some specific targeted items that would look at it to say, well, specifically what aspect of those 4 big goals are we going to be looking at, and ultimately the funding in the waiver is tied to. And as we mentioned last time, those 4 areas are increasing well child visits and well care visits for adolescents, also reducing the rate of ambulatory care sensitive admissions, and then increasing the percent of deliveries that receive a prenatal care visit in the first trimester or in the first 42 days of enrollment. I'm going to stop there with kind of the overview. I do want to turn now to the questions you have previously submitted and begin to review some of those. We will look at those, and then at a point a little bit later we'll open it up to Q&A from those that are actually on the phone with us today. The first question that was submitted that I want to make sure that I review with you was requested guidance around whether a professional association could work on behalf of and in partnership with the provider networks and with the RCOs to develop an IPS plan or application. And the answer, and I'm going to read several of these to you because the details matter and I want to be somewhat specific in what I give you back. Professional associations are encouraged to provide support to their provider members during the application development process, which must be disclosed in the IPS application. Medicaid must approve the use of any IPS funds to pay for resources or services provided by professional associations. In addition, any IPS funding to professional associations must be paid by the RCO using the portion of the IPS award that the RCO retains, which is up to 10% of the total IPS award. So from that up to 10% that the RCO can retain, out of that they would pay the associations for what they had done in terms of trying to facilitate what was happening. Obviously this encourages a lot of dialogue and the opportunity to make sure that you're coordinated and there's not a lot of duplicative work that's involved. So that is one answer. The next question I want to turn to is a financial one. I want to reference that to this particular question was relative to the requirement for providers to put up 10% of the IPS grant. The particular question said, if I understand the waiver correctly, the award to the provider would be 90% and the RCO may retain up to 10% of the total payment to the provider for administration. Is this correct? Does the provider have to have 10% available at the time of the award? Again, I'm going to read the answer here, and our finance person is here with us, Flake Oakley. I'll give him a chance to comment on it also. But the answer that has been developed thus far describes the fact that it references our special terms and conditions for the waiver. As I mentioned last week, anytime you get money from the federal government, there are strings attached. In this situation, those strings are described by the special terms and conditions associated with the waiver. Well, those special terms and conditions say that the IPS program will cover a maximum of 90% of the approved work plan or project's budgeted cost. The work plan or project's participants will have to provide 10% of the funding if the work plan or project is fully funded. The providers must have the funds available to implement the IPS work plan over the life of the work plan. Medicaid can ask for support to justify this funding, that this funding is available from providers included in the IPS application. The terms and conditions describe the fact that each IPS work plan, that a minimum of 90% of the approved funding will be distributed to providers to implement the IPS work plan. A maximum of up to 10% of the work plan could be maintained at the RCO level for administrative purposes. I'm going to stop there and turn it over to Flake. Any additional comments, Flake?
I think that the main point here is that each work plan or each project will have a budget, and that budget will be fairly detailed with respect to what the cost of the project is planned to be. And we would then make an award of an amount not to exceed 90% of that budget. So that will be some flexibility with respect to what the project cost components are that may factor into how much that award is. So it's really based upon whatever the budgeted cost of the project, what that total budgeted cost is. And as far as having funds available, that will depend on each circumstance, I think, as to whether or not we will only fund 90% of what the cost is. So that, depending on how the funds are going to be dispersed, would be determine whether or not those funds are necessary at the beginning or not.
Okay, great. Thank you, Flake. Appreciate that. I'm gonna go forward with a few more Q&As that we have received ahead of time, and then I will open up the floor. We did receive several questions that were pretty direct that I think are useful that I'll repeat without naming specific practices. But one particular question was basically, what does this mean for our practice? Now they named a particular type of practice. It says we are a specialty office located in a given county, and that they service about 6 counties. Obviously, this particular practice could work with one or more RCOs to develop an IPS application which supports one of the four targeted improvement areas. Then if that application is submitted by the RCO to Medicaid, then as we described earlier, that would be scored. Medicaid would also have some input and dialogue about that, and then there would be a determination made about an award pending how did it fit with the goals and objectives of the waiver, what was the funding like. And again, I want to stress, as I did last time, the importance of sustainability. What is this plan going to do? What is it going to develop that is innovative, that is useful, that the RCO would value, such that even after the waiver goes away, that it would be something that they would see great value in and would want to continue on funding or developing or utilizing. I think that's an important part of this. So that other information, as we've said previously, is on our website. We particularly have an IPS page now where you can actually go and look at the letter of intent template. You can find the RCO fact sheet. You can find the presentation from last week, and I guess ultimately probably this presentation will be on that same site. But there is a lot more information there. We did also receive a question regarding providers participating in multiple projects. The comment or statement was made last time that providers may participate in multiple projects if funding is not duplicated for the same work. They said, consider the following scenario. My organization makes a proposal to RCO1 to enhance access and care coordination for all providers in their network and makes the same proposal to RCO2 to do the same in their network. Would this be considered 2 separate projects since they impact 2 different provider networks, or would this be considered duplicative? Again, I'm going to read the answer because the details matter. Providers may participate in multiple IPS work plans if the IPS work plans are not duplicative. In no instance may a provider or RCO receive duplicative state or federal funding related to an IPS work plan. Medicaid will require RCOs and providers to submit attestations regarding the federal funding they currently receive and anticipate receiving in the future. In the scenario presented, the provider may propose the same IPS plan to all RCOs in its region if the provider has a signed contract or intends to sign a contract with each RCO. However, only one award will be made for the same work plan that is submitted to multiple RCOs from the same provider. So I do know that's a question that I've heard certainly more than once. That does remind me to remind you that as we mentioned on the last webinar, we certainly anticipate providers working with RCOs to develop plans that may not yet have a fully executed contract. Some might, but certainly those that anticipate having a contract can work in the development of an IPS plan. However, funds will not be distributed unless you have a fully executed contract. So again, actually receiving any money will only be to those that have fully executed contracts. And I think I also said last time, I'll stress again this time, if you do not intend to contract with an RCO, then this program is really not for you. And this is really not where you're headed. Okay, one last question, then I'll open the floor. If I have only signed a LOI to contract with one RCO and I submit an IPS LOI and application with that RCO, what happens if that RCO does not receive full status or pulls out? Does my application or LOI convert to the other RCO? The answer, and these answers will be posted eventually on our website, only RCOs are required to submit the LOIs to Medicaid. If a provider submits an IPS application to an RCO and that RCO does not go live or terminates its contract with Medicaid, the LOI would become transferable to another RCO. Providers will be responsible for submitting their work plans to another RCO in the region and requesting that the new RCO sponsor the IPS work plan. But again, it would be a decision by the remaining RCO. It's not necessarily a given that the remaining RCO would pick up a work plan from a now defunct or withdrawn RCO. If the plan is sponsored by a new RCO, the new RCO will assume management responsibilities for the IPS work plan and will be eligible to receive, again, up to 10% of the IPS award for the approved work plan. It does here also mention that providers must be contracted with the remaining RCO to continue to receive funding related to the IPS work plan. Okay, well, I'm going to stop there on the previously submitted questions, and now we're going to open the floor. I'll ask the operator to open the queue for us, and we'll be glad to take your questions.
Sure. Ladies and gentlemen, if you have a question at this time, please press star then the 1 key on your touchtone telephone. If you have any questions, ladies and gentlemen, you can press star then the 1 key on your touchtone phone. Our first question comes from Nick Letson. Your line is open.
Yeah, my question is, are RCOs obligated to contract with DMEs, or is it possible for an RCO to refuse to contract with a DME or practitioner?
Okay, a good question. We have in our law the any willing provider requirement, and that states that similarly situated providers, if a RCO offers a contract to a particular provider type, if similarly situated providers are willing to accept the terms and conditions of that contract, then the RCO must offer them a contract also.
Okay. Can I ask one more question, please?
Sure.
What happens to the RCO program if the state legislature does not include the required funding as required by the budget?
Sure. I mean, that's a great question. I'm not the best person to answer that question. The decisions about the state budget obviously we'll all be attuned to. We'll probably all find out about at the same time with headlines in the paper. But the decisions about how that would affect the RCO program that's really the subject of a whole nother discussion, and I'm going to hold off on that. We really want to focus this webinar on the IPS plan or program and focus questions about that.
Yes, sir. Thank you.
As a reminder, ladies and gentlemen, that's star 1 if you have a question. Our next question comes from the line of Latrell Porter. Your line is open.
Yes, I'm calling. I've been listening to these calls that you've put on, and I'm just a little confused. I apologize for my ignorance here, but how hospice providers fit into this scenario? Is there application process as an IPS, or are we outside of this altogether? I've talked with others across the state, and we're just a little confused as an industry as to how this impacts us.
Let me clarify one thing. And as I mentioned earlier, to really receive money from an IPS, you have to be a contracted provider. And the discussion about hospice is important because those particular sets of services are excluded from the RCO's responsibility. So the RCOs, we would not anticipate the RCOs contracting with a hospice entity, at least for sort of typical hospice services.
So there would not be a need for us to do any kind of, or complete an application process as an IPS or any other, we don't need to take any action at this point.
Well, certainly, we don't want to say anything you can't do, but I can tell you that the responsibility of the RCOs is not to cover hospice services. So, generally the answer would be no.
Okay, thank you.
Okay.
Our next question comes from Nestine Tucker. Your line is open.
Thank you. Dr. Moon, can the IPS funds be used for construction projects?
I'm sorry, IPS funds and construction projects? I didn't hear the middle part of that.
Can funds be used for construction projects?
Yes, ma'am. We do anticipate that perhaps being part of some of the plans that we might receive. Obviously, there is no guarantee that any of the IPS plans would involve a construction project. On the alternative, they're not excluded.
They're not excluded. Thank you so much.
There are no other questions in the queue.
Okay, wonderful. I do know we've had other questions submitted to us, which we will be developing answers for, and we'll be publishing those answers via our website. I do believe that we have all previously shared where IPS information will be found, but if you look at the Medicaid website, the main page, the bottom left-hand corner, there's an RCO icon. You can click on that. That will take you to an RCO-related page. And I believe about the first link you get to on that page is going to take you to the IPS-related information. So you can continue to follow those links and get much more information. We do anticipate continuing to push out answers, and we encourage you all to submit the questions that you have so that we can continue to provide information. We recognize this is a big program. This is a big issue, and the timing is extremely aggressive. Again, it is related to the timing of the waiver. Ideally, we'd all have more time to be able to develop and work on these IPS proposals. However, we don't because of the timing of the waiver. So if you're going to engage, if you think this is of interest, engage now. There is also on the IPS page, there is information about who in each RCO you need to contact to actually say, well, have you thought about this, or what kind of ideas do you have going on? How can I be engaged and participate? This is a program where dialogue, communication is extremely important. We view that the best plans will come out of the most robust dialogue to really prioritize and develop plans that will be the most effective, have the strongest return on investment, and then just make the largest change in terms of moving the performance on these metrics. Again, the quality metrics are extremely important. The additional monies that we are receiving as a result of the waiver are tied to our performance on these metrics. The concept is that these IPS plans will move the needle in terms of achieving the objectives of these particular metrics. So I encourage you to look at them very carefully. All right, any other questions in the queue?
Yes, we have a question from Danny Rickett. Your line is open.
Dr. Moon, actually I have three questions. One is a statement. From the RCO standpoint, since the RCOs have to submit to the Alabama Medicaid agency by close of business April 15th, a provider really needs to get their LOI and information into the RCOs prior to that date in order for the RCO to meet that deadline. If we could make that clear, we would appreciate that.
Okay, I agree. The RCOs are responsible for getting information to us, LOI information to us by the 15th of April, which obviously means that, again, now is the time to be active and to be engaged with your RCO. Absolutely agree with that. If you wait until the 15th of April, you're going to be too late because we're talking about the development of a plan, and subsequently by the 15th of April, we would anticipate the LOI coming from the RCO. So again, the providers need to engage before that.
And next question, provider has a project that they're currently working on and they want to submit a plan for a project that is already in process. Is that appropriate, or is it only for projects that are anticipated that may be approved, or is it potential for funding to be for a project that's already in process? And if so, how far back could that process have started?
Danny, I'll have to take that down to give you a detailed answer, but my understanding is these are new projects. These are new things, new expenditures, but we'll take that question down and make sure that we give you a more detailed answer.
Okay. And then the final question, under the types of providers that may participate, we have a category of other providers to be approved by the agency. Is it anticipated what might constitute other providers, or is this on a case-by-case basis?
Well, there is the general requirement that they're contracted with the RCO, but beyond that, no. We've not tried to limit the vision of what that might be, because it may be that there is some innovative proposal that may come forward with a contracted provider or provider group that we had not anticipated. Actually look forward to that sort of thing, but there will be the limitation of it being a contracted provider.
So just to give you an example, a transportation provider is a provider who has a contract with Medicaid that potentially has a contract with the RCO. That would be considered a qualified provider, correct?
That is correct. That would be a contracted provider.
Okay, thank you.
Okay. All right.
Our next question comes from Allison Todd.
Hi, Dr. Moon. We just have a question as we're developing our IPS regarding to Medicaid coverage. Will Medicaid coverage be expanded to cover women between pregnancies beyond the current 25% that are eligible for full Medicaid?
That's a great question, Allison. We are not currently, this program is really about the eligibility groups that are covered and are included in the waiver. There's not really been a discussion about expansion of coverage. Having said that, though, there was an alert that went out regarding our maternity clients in the amount of Medicaid coverage that they have for SOBRA clients in particular. And I encourage you to go back and look at that. But we do not anticipate an expansion of new individuals. Again, that becomes a state legislature sort of question, not a Dr. Moon question.
Our next question comes from the line of Steven Adderholt. Your line is open.
Thank you. Real quick question. Can you give us an example, maybe, or just a quick synopsis of an IPS program that you anticipate being funded, and I guess a little more definitive than that? Again, I know you're looking for innovative solutions, but do you have a model IPS program somewhere theoretically that you're seeing this looking like across the state in certain respects?
Sure, that's a great question. What I would encourage you to do is to go and look at DIS-RIP projects that have developed in some other states. For example, Texas and New Jersey in particular. They have DIS-RIP programs, again another acronym, but it is meaningful in the sense of they are typically projects or plans that come forward to actually drive and improve the quality of care. I'm not saying that any single one of those necessarily would fit in our situation. However, that might give you some ideas and some concepts that you could utilize to say, well, okay, well then I kind of get a feel for this and have a feel for what might work. Again, I stress that the plans that address larger populations that have a bigger effect, have a better ROI, all of those things are going to be important. So when you do look at the DIS-RIP, it's DSRIP, I believe is correct, the DIS-RIP projects that exist in those other states, again, think about how that would translate to Alabama. There may be elements of some of those that would fit here, may not be. Again, you'll have to look at it, but and then you may say, well, they did it this way in Texas, but we want to do it some other way in Alabama. And those would be a couple of places where you could generate some ideas. Another state you could look at would be Oregon. Obviously, they have a program that their coordinated care organizations are similar to the regional care organizations that we're developing. So I would encourage you to go look at some of the work they've done in Oregon to actually drive the performance metrics that they have. Good question.
Great. Thank you.
As a reminder, ladies and gentlemen, if you have a question, that's *1 on your touch-tone telephone. Our next question comes from Katie Cheatham. Your line is open.
Yes, I represent a skilled nursing facility in Alabama, and we need to know how will the reimbursement rates be established that we will bill for services rendered.
Sure, it's a great question. Long-term care, those populations, those services are actually excluded from the RCOs. As it exists today would be how it would exist for you, once the RCOs start, because they won't change what is going on for, long-term care services and the waivers and that sort of thing. They're actually excluded from the RCOs.
Our next question comes from the line of Ann Belsko. Your line is open.
Yes, thank you, Dr. Moon. I think this might be important to the providers and it's of interest to the RCOs. On the template, the LOI template that the agency has provided, there is just a small box for a project summary, and was wondering what the agency is anticipating in addition to what would fit into that box in terms of a summary for the letter of intent.
Okay. Well, the box is not a artificial limitation on the size of information you can submit. Okay. You could attach a whole other document if you so chose to do. Certainly I believe it's based off an Excel spreadsheet, so you could fill in there as much as you wanted to.
I was wondering if we could attach a few-page document for each letter of intent, and that would be helpful to the providers to send to us as well.
Absolutely. Absolutely. Okay. Our hope, though, is what we didn't want to do is we didn't want to generate an LOI process that was so burdensome, that you had to submit a 300-page document to even have an LOI sort of plugged in. The goal was to try to keep it as simple as possible, but we have no problem with you. If you want to give us more information, that would be excellent as far as we're concerned.
All right, thank you.
Again, ladies and gentlemen, if you have a question, please press * then the 1 key on your touch-tone telephone. There are no other questions in the queue.
All right, great. Well, then we'll begin to wrap things up then. Certainly we appreciate everyone that has participated in this call and the questions you've asked and the ones that have already been submitted, and certainly we'll continue to work on questions you submit and push that out. It may be that we'll need another webinar in the future depending on what kinds of questions we're getting and whatnot, but we'll hold off on making that a firm commitment right now and just see what volume of questions we get in. I would strongly encourage providers to dialogue with your regional care organizations that you're involved with. So many of the questions I think will really be questions for the RCOs to work with, and obviously what specific plan you come forward with in any specific region of the state may be different, very different from plans that we see in other regions of the state. Issues and health care frequently vary depending on where you're located at exactly. So please, I encourage you to dialogue very soon with your regional care organization. Having said that, we'll stop. I'm not sure from the technical folks if there's anything else we need to do at this point, but we do appreciate you being part of this today.